Yes, okay. This is a training on attachment versus love. David Kazmierczak, I'll hand it over to you. You can present yourself and the material. Okay. Thank you for
Okay.
being willing to do the training again by popular demand.
By popular demand. Okay. Well, thank you. That's a courtesy, and I appreciate it. This is really about the combining of two models in order to really consider or highlight the special importance of relationalness in trauma work. And that always really, in my opinion, always sits on some level of attachment and being cared for or loved. And so there are many different ways to approach this, but the one that I've chosen is Matt Hussey put out a book, and he's quite popular on the YouTube. And his book is called Love Life, and it's about 4 functional stages. And what I found was is that those stages seem to be very intimately connected with 8 phases of EMDR. And there, everybody should have the handout now. And if you don't have it, let Frank know so that he can get it to you. And I think that Isabel may be putting it also in the chat. So because I saw that connection, and then I started to work with these two things, because I very much find that EMDR work assumes that we are good clinical people already. That is to say, we have experience and we feel practiced and we seem to know something about what we're doing and all of that. And my experience is that many times where we get stuck is that we have gotten so caught up in the trauma, so caught up in the 8 phases, or trying to move the material forward on behalf of the client, because we might feel their pain, we might feel that traumatic impact. And so it mobilizes us, and we begin to get caught in that. In some ways, in a classical way, we might say you have some countertransference. But the fact of the matter is that there's another way to look at this, which is that you're really trying to respond to the attachment issues or the attachment damage that has come maybe in earlier life that has set the stage for trauma, or that the trauma itself has reawakened things that were relatively consistent, relatively clear, relatively well managed, only to find out that there's unfinished business, and then you can get lost in going back to the early material. So how do we bring that into the here and now and do the two things together at the same time? Now, in the best world of all worlds, I would say that we need to be able to address these kinds of earlier wounds and stay on the present targets as much as possible, even if the present target is that somebody's working on something much earlier in life. But the idea is they're working on it now, and therefore it is in the present time. So the presence really requires, which is very core to good trauma work and the adaptive information processing, the AIP model. And because it's so core, I think that if we could find a way to objectify how we can deal with attachment and love issues, or love wounds more likely, the kinds of distress that happens are usually wounds. So those wounds, how do we address those things and still stay on the focal point, the target area? And so if we can understand the relationship, we can begin to move between both of these models, both of these approaches at the same time. And most of the time, it's just going to be your ability to hold a perception about what you're encountering in your relational interaction and intervention models or steps, skills with your client. And so there's a few things that I think are core that we have to just ensure that we're in agreement on. And once we do that, then we can go through the actual 8 phases and the 4 stages of relational love that I think really has a very current way of speaking about attachment, because attachment so often makes us go, oh, well, we're back to 2-year-old and 3-year-old and all that kind, or infancy or whatever. And that may be true, but there is a way in which it's showing up today because it has surely shaped every one of us that, and it's still present now. So holding on to this idea that we need to sustain a more conscious awareness of relationalness while doing trauma work is very important. So with that said, how are love and emotional attachment different? Attachment cry is what happens when there is fight or flight that has failed. Now, fight or flight's in the back of the low brain, reptilian brain, right in the medulla oblongata area. And that's the need to survive. It's not really good problem solving. It's usually about, am I safe or not safe? And the important factor is that if that's the case, trying to use verbal problem solving may not help. Moving into emotional management gets closer to it because as you start to engage in affect and emotions that are attached to that, you get closer to the nervous system that is attached to the low brain. And that attachment cry, which we are born with, which we have since infancy, that attachment cry is a hardwired response to danger. So trying to be heady with somebody, well, maybe if you and I sat down right now and talked about anything, it wouldn't feel heady at all. But if I'm desperate to try to get enough oxygen because I'm having an asthma attack, let's say, or I'm really distressed because somebody that I love just died unexpectedly, then this conversation could sound very heady and it could feel very disconnected. So being able to get to that through the emotions is a good signal help. But you can't do that if you don't also appreciate the importance of this statement that the attachment cry happens when fight or flight has failed. We need to recognize that, not just go, oh yeah, I see that. No, 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 no. When I say that, what I mean is that the attachment cry is a signal indicator that survival mechanisms are failing, which means that the other factors that go beyond fight or flight are likely to get activated, which is freeze and collapse. And let's not forget that freeze and collapse opens us much more than just fight or flight, much more to becoming hypoxic, low oxygen. And so using words and dialogues and cognitive work is not going to do very well in that kind of condition. And if you don't recognize it, and believe me, it's easy to miss. There are very good therapists who miss noticing when somebody is actually starting to collapse. Client starts to slide down in the chair, they become a lot more yawny, they start to find themselves being a little more drifty, and you're just kind of going, well, maybe they're just relaxing into it. You got to check it out because they could be sliding into a dissociative state. And more than that, they're literally sliding into it biologically. So we have to be able to go there. So if you were dealing with an infant, because we're talking about infantile survival, if a child is starting to just give up because they've cried their eyes out and they can't speak and they're just exhausted, they're sliding into freeze or collapse. And most parents would, by that point, have started to pick the child up. You start to connect. You start to touch. So this is very much that idea of that we need to know how to touch with our clients. And I mean this in the healthiest of ways. How do we touch with our clients in order to help them know that they're connected? Because freezing and collapsing and fighting and flighting is a distancing mechanism for survival. And so somebody needs to be close enough to be able to induce a state of connection. So staying connected and working on the trauma is what the heart of this is all about. That's the heart of it. So the attachment cry is a hardwired response to danger that occurs when the primitive brain believes that escape might still be possible after the fight and flight have collapsed. It's a last-ditch attempt, but the cry may not be a loud cry. It may be a passive cry. It could be that yawning. It could be that sleepiness. It could be that body slump. It could be many indicators that we would just go as the client seems like they're getting a little avoidant, or the client is withdrawing, or the client is present but doesn't seem as motivated. They're not as energized. There's a loss of energy. Those are signal indicators of the last attachment cry. Again, the last attachment cry in that moment. So letting them go further than that is not a good idea. Is emotional attachment the same as love? It is interrelated and it's distinct in the following ways. Love and attachment can appear to be interconnected, and yet they are distinctly different in this way. Love is the feeling that is directed towards an other, the other person, place, or thing. Other focused. Attachment is self-centered in a healthy way, meaning based on the fulfilling of a need, not desire, of a need. Be able to distinguish that. So it's very important to try to get this very clear, that the simplest thing you can do is ask yourself, is this person talking about others, or are they talking about themselves? And in trauma work and EMDR work, we're always looking at, and what did this do to you? And how did this impact you? And what does it leave you saying about yourself? That's that entrance into where the attachment is. It's that entrance into where the client needs touch and safety in their exposure to the actual trauma. So understanding emotional attachment and relational trauma patterns are very important, because the trauma pattern, especially if it's in a relational aspect, and in almost all cases it's relational, there are times where it's situational. You're on a plane and it goes down in an emergency, or your leg gets caught outside the door of the train, that's closed and the train is starting to move. Those are incidents that it's just the person in the situation. But inevitably, the person will say, nobody came to help me, where there's no rescue. I was alone. And so it begins to affect then further future relationships and what their trust level is in terms of moving forward. Hussey's model he's really more about relational and romance and successful and unsuccessful ways of coping, especially in today's world, relationally. And his work, while not academic in the traditional sense, is very well researched, and he really bases things on some very powerful, good studies and classic theoretical content, and then takes that and applies it in today's world. And he's devised these 4 stages: the stage of admiration, relational admiration, the stage of mutual attraction, the stage of mutual attraction or good chemistry, but no commitment, and mutual explicit exclusive agreement for an exclusive relationship. Now, I want to be really clear on this. An exclusive relationship, in the way that this is meant, is not to say that it's necessary, a classic ancient model of marriage that says we are married forever and ever, and we are only married to each other, and never shall we in any way violate it with another person. That's not what it means. It means that your agreements are explicit to the point that you remain committed to each other, that there is primacy, and if that includes polyamory, then that's that. If it includes open relationships on one or both individually, together, or a potpourri, or any other combination of things, then that's still a committed, explicit, exclusive relationship. So just to be really clear, that's why I like this, is that it really allows for many things that are going on in today's world. For many people, it might be a little surprising that it's much more than what we might think. And then the fourth phase is compatibility. And this can only happen. Compatibility, you can have compatibility at the mutual no commitment level. And then but its full development doesn't happen until you've moved into compatible on the mutually explicit exclusive relationship. And the reason for that is that the degree of trust increases on both sides. And it's not just on both sides, it's also where there's a we. I like to give this little model of relationships are person one, person two, and person one, hi, person two, hello, what's your name? Getting to know each other. Your fingerprint, my fingerprint. I'm fingerprint one, you're fingerprint two. Very good. Okay. Oh, you like to play pinochle too. Okay, let's get together. And before we know it, we have an us. We've created a little world where we have you and me getting together pretty routinely, and there's an usness where you have friendship. Isn't this lovely? And if it's not friendship, it's some kind of camaraderie, fellowship. And isn't that lovely? Yes, it is. And then if we get to know each other even better and we still like each other, whether or not there's good chemistry in terms of intimacy, sexual intimacy especially, then what we start to have is a we. The problem with we is that so much of what happens is that people forget that they could also move out again and create greater distance, time management, physical space, and go back to an us and go back to the we and go back to an us and go back to a we. A lot of people do that by going out to their jobs and coming home, and they don't even realize that that's what they're doing. And they often are talking about, when there is a we, they're talking about what it was like for you. What was your day like? What was your day like? Oh, yes. Uh-huh. Mm-hmm. Yeah. Uh-huh. Okay, good. You're all about the usness. You're still distant. You're not really moving into intimacy. But the importance of what I'm getting at here is that you need to be able to always, in all relationships, you need to always remember, never should you foreclose on yourself. And if you can do that for you, then you'll be able to model that for your clients in your therapy. And you can do that in your friendships, and you can do that in your intimate relationships, your us relationships and we relationships. So it's very important, this idea that we have some kind of model in our minds about what is healthy relationalness. And there's so many different models out there. I just happen to think that this model is simple enough and relatable enough that it works. And surprisingly, it seems to work very well within the EMDR 8 phases. So the goal here today is healing relational patterns and building secure attachment through EMDR informed understanding. And I'm saying informed needs to be more explicit on attachment. The presumption is that we are all already experienced therapists. Most therapists that stay in the EMDR work or trauma work in general are long-term professionals. And the people that were sort of brought into it early in their career, universities and colleges that include it as part of their graduate clinical training, those folks often also continue. And sometimes they take a break for a little while and then they go back into it. But they're much more ready and they feel, oh, now I feel more confident and they're more capable. And they go online and they work. They do fine. I don't mean online like what we're doing now, but they're continuing in their professional work and deepening it. All right. Now, before we proceed into the 8 phases, and then there's going to be some active involvement that I'm going to look for from you folks. So I'm going to hopefully interact with each of you. Questions, comments, considerations. Now you should be able to be looking at the document so that you can not just listen to me and then forget the thought, but be able to reference back, because all of this is connected to just those first few sentences. No, yes, no hands going up, no comments. Everybody's got it. It's too simple. How many people, raise your hand, how many people think it's too simple? How many people think it's too hard? Okay, so how many people think that it's in the middle?
It's it's definitely in the middle the way you've laid it out. Particularly the grid that you've created to compare the relational stages to the 8 phases. That is really useful. It's very simple. It's a fabulous assessment tool to determine where the therapeutic relationship is. That's pretty cool. And in terms of what your focus would be on targets based on where the stage of the relationship is, that's very clear and very useful. I like the idea of the perceptual, the need for resourcing and perception, mixed signal length. That category is really shows you where the work needs to be done in terms of building the relationship, but also in terms of resourcing the relationship and resourcing the client's experience.
Yeah, I think that it really, for me, it really very, very quickly clarifies what does the client need now?
Yeah.
Right
Yeah.
there. What do they need? Whether they can tell it to you or not. You have to make the assumption and and then test it out. And they will tell you. I mean, clients are really pretty good once they know that they're safe enough with you.
Yeah, I wanted to say that what stands out for me, I was coming in and out because of the kids. I needed to interrupt her a few times, so I wasn't unfortunately able to listen to everything that she said. But what she said about the trauma response, the level of activation, that really spoke to me. And to me, it's very practical. Would be, like when a child is crying, screaming, then we're not talking about anything at all. We're first talking about, okay, how do we calm down? Let's, wait for you to calm down. I'm right here with you, right? Like, so, and it's very applicable to the clients, and it informs my decisions now it's very now, cleared that part for me to what do I do if I see client in distress. And it also, the hardest part is if distress is caused by something in therapy, they're distressed by therapeutic relationships, and then how hard it is to address it, how hard it may be for me to address it, and then kind of gives me the point of view, right, where I'm like, okay, they are distressed. This is what's happening. It doesn't matter if it's about me, about anything else. Now we're finding a way to calm down, just like with in my parenting experience. So thank you. That was really helpful, the part.
Okay. Yeah. So self-regulation is always key. And I think that, allowing someone to bring out their experience, we're not looking to abort every arousal. letting people have dynamism is an okay thing. But I think that when it's going outside the window of tolerance, then that's important. And also when it's starting to go outside your window of tolerance. And sometimes it's very important for a client to be told, this is so outside what I would find acceptable as some kind of order and control and some sense of balance that I'm very stunned that you're just going through it as if you're just kind of walking along the beach, having a fun time. And they'll go, what do you mean? Like, they're so normalized. They're so normalized, they don't even recognize it. Or maybe they've never known anything else. And the scary part is that very often is that the scare that they're experiencing is the scare of being calm, of going slow, of having someone that's staying with them.
Isabel,
Because relationalness is all about witness.
Isabel, hand up. Yeah.
Isabel.
Sure, thanks. Yeah, what you shared just now, David, I feel like just that last part was very much kind of what I was leaning into hearing this so far. And I think about, this client that you and I are working with right now, David, and this person we were just working with yesterday, and this, like the relationship as this, the therapeutic relationship as this ground for, addressing like, well, what is attachment cry and how is that happening with us? And what is, that real love in the sense of like real emotional witness and cooperation and like choosing to be in an experience and to like deepen into it and learn about it together with that shared goal of like honoring what is real and true and alive in this space. And I I'm just finding a lot of value and oh wow in the way you've put these things together. Um, and also having that recent example, that experience of like seeing it in real time with someone that we are working with who kind of revealed like, oh, I'm afraid that I'm being rejected in this relationship. I'm like, that's what's arising for me. And that love and like attachment fear can be so like close together that it can be really hard to tell the difference.
Yeah.
Hmm.
Yeah. Yeah, very much so.
Hmm.
Yeah, I mean, there is a place in their complementarity. There is a place where the boundary is blurred. That stance is blurred, and which one are we dealing with? What are what's coming up here? And we have to be, willing to go through that with the client. But if we can see it, then it can give us, some pretty good. We can stand on our 2 feet and go through things as opposed to kind of muddling through in a way that we're on all fours in the playpen, just kind of infantiling it together in a certain way. Okay, anybody else? All right, let's take a look at your handout and go through the 8 phases. And while we're doing this, what I'd like to do by the time we're done with this is I'd like to give you all 5 minutes to literally pick out a case that you're working on or have worked with, and that you think is a good example of one of these 8 phases and the relational stage, the kind of mixed signals that you were picking up, and what you did. And what you did then, and what this might have informed you about how you would do it differently. And I really would like to do just a full round robin on that, because I think that way it will land for each of you, that each of you will be able to bring it to see whether or not it fits for you in the work that you've already done. Because otherwise, this is just another interesting piece of scenery along the way, and one that maybe you just go, not that interesting. And I'm very much more interested in the functionality of this kind of thing. Is that okay with everybody? Does anybody disagree with that? No. Okay. Great. So The EMDR phase is first, then the relational stage, which is only one of four. The mixed signals, which is really like the positive and negative cognitions. You know, the people, I love you. I beat you because I love you. You know, I've heard that so many times from so many people. Well, my parents did that. Well, no, my husband did that. No, my lover did that. No, my wife did that. No, my kids did that. Oh, I'm an elder and my kids beat me because they love me, because they thought I was doing wrong. What? People really, honestly, that's how they resolve mixed signals, the pushes and pulls. Okay, history taking into the treatment planning phase and preparation. We'll do one and two. The admiration. Now, admiration is this. Wow, this client, you know, you folks who've done pre-intake, you know, preliminary intake, you might admire a client right away, or the client might admire you. Oh, the client's really verbal. The client's really was concise. Oh, the client was very cooperative. Oh, the client followed up and got back to me right away. They did everything. I think they're going to be good. That's admiration. We don't really know them. You don't really know them. They don't really know you. But there's something that it could be a physical attraction. They like you because you're a female. You might like you because you're a male. They might like you because you're bald. They might like you because of whatever. We don't know. But admiration is just that. And admiration is a place where a lot of people live relationally. A lot of people live in that space. And it's not a very intimate space. And it often sets the stage for lots of inconsistency. And in today's world, it shows up a lot with people who are learning, meeting and connecting with people online. Because, oh, I find you attractive. Oh, you say the right words. Oh, isn't that great? Okay, admiration. It's a one-way interest. Even if both of, like the client says, oh, I really would like that person who interviewed me. I'm glad to meet you too. And then you know, I talk to the staff and the staff will say, oh, yeah, I thought that this was a great client. There's actually a mutual attraction going on, a chemistry. But the fact is that it's admiration. But nobody really knows why. There's not much substance to it. So this is a time when people can also inadvertently overinvest. We're willing to start taking clients in. I think it's a very good idea as clinicians to, as good as the client can appear, it might be very relevant for you to actually give yourself a few sessions and say, let's see how this works out in the beginning sessions. And if it works out, then we'll continue. And if not, then we won't fully admit you into our practice, but we will move you forward we'll refer you. A lot of people feel offended by that. But the truth is that after 2, 3, 4 sessions, you each know a whole lot more about each other. And it might be just really wise to say, oh, I think it'd be a good idea for you to see somebody else. And get the client's feedback. Idealization is what this is all about. This is about, it's a romanticized limerence phase of, wow, isn't that person really cool? No, Hollywood is all about that. The danger of this is that it's all about fantasy and more seriously when we call it selective perception. Selective perception is the equivalent of blocking. I only see this component and I don't see the rest of the picture. I can't see it. I don't want to see it. I don't need to know about all that. Oh, you don't need to know about all that. Those aren't the droids we're looking for. Okay, it's a little bit of a trance state into our fantasy world. It's a form of hypnosis. And just so you know, from a certain therapeutic posture, romantic love is generally considered a trance state. It's not considered actual love. You're in a fantasized, idealized, romanticized limerence. And nobody wants to talk about that because why would I want to give that up? Okay, so in your handling of this, you need to identify the attachment patterns. The client who comes in and is too close too fast. Do you do this with other people? What's this? Is this how you? Oh, well, you've been through 3 marriages in 2.5 years, and what was your life like before that? Oh, I was alone for about 18 months, but I always had somebody. Okay. This is very important to identify the pattern of the relational history. And what are the triggers for the admiration or the fixation? Because what the reason for it, excuse me, may very well be something that will show why the person is inclined in certain ways. I know of somebody who was controlled by the parent's voice. And the parent's voice was so strong that they really felt that their actual behavior was being dictated to them when the mother wasn't present. The imprint was that strong. And they, as an adult, the only place that they could really find that they felt a connection besides their partner was church involvement. Because, well, why? Well, because it's a great religion. It's a great idea to share with other people. It's a great, and what was the problem? Did you ever have a problem with the church? Oh yes. Oh yes. They're so judgmental. They're terribly judgmental. And how did that work for you? Oh, not well at all. But I'm so hurt by the church. I can't let go of it. But it's so loving. They're such wonderful people. The ambivalence, that push and pull, that yes, no, that mixed signal. You can see that very often right in the history taking phase. And usually it's about what they didn't get. And they're still crying out for it. That's the unmet need. Preparation phase. This is where there's some mutual attraction. Yes, we can work together. Let's look at some of your resources. You're starting to ask them to disclose very private information when you ask for their resources. Very private information. This is my most favorite spot. I rarely take anybody there. I don't want to overexpose it. And we just say, oh, just tell us about it. And what does it feel like? And where does it land in your body? And how is that for you? And we just go through it like, isn't this lovely? And oh, this client's workable. They're disclosing. And oh, isn't this great? You're being transparent. I'm being transparent. Well, where this is creating a mutual attraction to each other or engagement of the clinical relationship. We need to make sure that we're building safety and resources that the client already has, teaching grounding, and ensuring self-worth. You are worthy of this investment of time. You would be very surprised how many clients move right through this and how many therapists move right through this without even thinking that that needs to be explicit. It needs to be explicit. Not overly explicit because it's still an early phase in the treatment phases. But it really will tell you a lot about how they handle things that are not very explicit. And what you find out is that they're in lots of relationships where they don't really know a lot about the other people. They really don't know much at all. But they're good enough and they roll through it and they just move on. And then they wonder why they get wounded. So this is an important area in which to differentiate attention versus affection. This is an important place to distinguish, just like it's an important thing to distinguish the difference between the attachment cry and love. One is other-focused, one is self-focused. And in the same way, attention So people who are craving attention and misread that as affection will become very vulnerable to love bombing. And there's many ways that that happens, but it especially happens where there starts to be mutual attention, mutual attraction starts to develop. It's a natural phase of relational development. It's a natural phase of relational development. It usually is not long-lived, but in the beginning, there's kind of this, oh, I really like this person. Oh, I really want to learn from them. Oh, I really want to spend time with them. Oh, yeah. And then you get to know each other a few times and suddenly start to see that there's more to the story. So attention can feel very good. Affection can feel like a natural outcome. You can feel an investment in someone, but it's just the preparatory phase to see what comes next. And a lot of times how many of you, just, you don't have to answer but to me, but just answer it for yourself. How many times have you moved forward through the history and preparation phase with the idea that this is moving forward, that everything is sort of okay, and that there's kind of a workability that I trust this is going to work out. And you haven't really answered the question, is it working out because we're giving attention, or is it working out because they're feeling that they're getting some affection? Because this will haunt you down the line. It'll be a confusion between love and intimacy and like that. A lot of sharing, people on teams have a lot of affection for each other, and they get a lot of shared attention. That doesn't necessarily mean that it's actual love. It's more about security. Third phase, assessment. Mutual but no commitment. By now we're talking about the treatment plan, we're talking about their strengths and weaknesses, and we're moving also into positive and negative cognitions, which is a very difficult thing. This is a phase in which ambiguity is important, or ambivalence. Ambivalence is right here, midbrain. Midbrain functioning, ambivalence. It's SUD levels of 4, 5, and 6. And ambivalence is ambiguous, produces ambiguity. Very important to understand that. This can produce heightened anxiety, push-pull, attract, avoid. And it is usually at its greatest during assessment because they're taking big risks and you're inviting them to take risks. And you do that in the name of your role. You do that in the name of what you're doing. You do that in the name of I want to help. But are you asking yourself, how is that help being received by the client? And how do they handle ambiguity, ambivalence? So identifying the target memories, past experiences of rejection. I think, Isabel, this is what you were referring to as what this shared client. Surely what happened was this was all about history of past rejection. Abandonment, uncertainty. Yes, I want to have this relationship, but I haven't really had a successful one in my life, or I've had so many people that have let me down. They're just never there for me. Or they've been betrayers. They betray me. The Judas kiss of betrayal. Ah, terrible, just terrible. It doesn't take much if you just look at this and then you take a look at a good breakdown of attachment theory, ambivalent attachment, all sorts of various kinds of attachment. You'll fit into this model very easily, very quickly. I didn't have the time to bring that into this. But developing a clear future template for self-trust. Notice that. Self-trust. Notice that. Self-trust and boundaries. Not other trust, self-trust. Ambivalence requires you to trust yourself. Look, I'm standing here patiently and I'm offering you at the delicatessen where you've gone in for your ice cream. I'm offering you 22 different flavors. And you are free to choose as many of them or any of them that you would like. And oh, there's too many choices. That's kind of what we're doing in therapy. Too many possibilities, too many different ways, too many different options. And we need to let the person trust themselves to make their decision. And if we are influencing them, then we are, in the best of worlds, we are doing something to benefit them, but we're persuading. And all communication is persuasive. Just know that. All communication is persuasive. So there's no way out of that. But there is a way to use your communication that also, in the name of persuading you, I want to bring to you 5 different, let's limit it to 5 flavors of ice cream. How does that sit with you? Yeah, that feels better. Okay. So tell me what you like about each of them and what you don't like. And as you're doing that, you're going to know which one you have a taste for right now. You can help them along and you can use your intentions very positively in this way. Desensitization, commitment is being made here. You don't move into desensitizing unless, yeah, this is really bothering me. Yes, okay, yes, let's go with it. They've agreed, you've agreed, and let's go. And, I think that earlier, Brian had brought up the idea of, you bring up one thing and then they do a float back, and the next thing you know, you've got a whole other target that's going on, and then they're really running into each other. And, are they the same target in the same category, the same channel, or are they actually cross-talking two different things that are going on parallel to each other? So one is cross-talking, and they're in different channels, or they're in the same channel. That's good to know. But the important thing is that this is common for ambivalence to bring this up and exploration to bring this up. And when you start to commit to doing one thing, whatever resonates is going to come up. How do you deal with that? You deal with both at the same time, or all 3 at the same time. Believe me, it'll show. The one that's primary will come up. It'll become self-evident. So you're processing the triggers and the old beliefs. I'll be abandoned. By the way, notice something here. We're talking about old beliefs as triggers. The word trigger is used in recovery work, and the way trigger is used in popular support groups, and the way it's used in ACA groups, the way it's used in AA groups, NA groups, is not the same thing as the way we use it. So be conscious of that. People often use triggers by definition in very different contexts. So this is about old beliefs that show up. And you're looking to reduce the charge so that they can make a commitment or a rejection about it and then replace it. Okay, installation, an explicit agreement, an exclusive relationship, the trust testing, fear of betrayal, hypervigilance. These are very important. That we need to help people sort it out. And you can only do that if they're feeling that there is an agreement in the relationship. And isn't that really exactly what happened in that session you were referring to, Isabel? Needed trust test. She needed to test the trust by being able to talk about it in the relationship, not out of it. And of course, she projected, I'm out, based on past experience. All right, strengthen the positive cognition. I can be loved. I can be safe. I can be safe in commitment. And reinforce the inner sense of worthiness and trust. Body scan. Now we're into the compatibility. Notice we've moved through an exclusive relationship. Now we have compatibility. And let's remember something. Let's go back to Hussey's 4 stages. Therapy is really about mutual no commitment and mutual explicit commitment. We constantly are moving between these two because we're holding boundaries to sustain the therapeutic tension and the safety in the therapeutic relationship. And at the same time, we're becoming very close, which can become very confusing for both the client and the therapist. The important thing is that these things need to be very well explicated. If the relationship is getting too close, too much, then maybe it needs to be discussed. So do we want this then to change into something that is social and non-therapeutic? And if that's the case, we need to have a break. You need to be referred to somebody else. And if one or the other can't hold that boundary and do that choosing explicitly, then that is a very important clinical issue to navigate together and let it take the time that's necessary. Go through it, live through it together so that you're helping the person really come to terms with what they need to do. And if you need help sorting that out, then you need to go to supervision and talk about it. Not once, but again and again and again and again until you desensitize so that then you can make conscious, intentional choices. So the body scan, these are about core needs. The body is speaking to the client. The body is telling you something, the therapist. And these are residual tensions from old attachment trauma. And so the body will body work, somatic work, most often puts you back to early situations. So when you touch in on a body scan, you want to make sure that it's in the context of what you're working on. If I'm working on an automobile accident that happened in the last year, but my body has something that's going on that's residual that takes me way back, do you really want to, as a trauma therapist, necessarily go back there? Is it necessary? You might recognize it and you might say, we could consider that, but we should finish up this target. Because you've gotten this far, don't get it confused. So always within the context of what you're treating. Notice the somatic responses to closeness, to commitment, to safety or lack of safety. Help clients integrate sensations of calm connection. Helping people to slow down, breathe slowly, calm down. Remember, residual tension is an arousal. They're not calm. There's some aspect of them that's still aroused. They need to recognize that so that they can identify it better. And you need to be objective to it. Closure, maintenance of compatibility, secure bond. That's not the same as we're moving into continued mutuality and further compatibility. This is a big challenge for community work. People in communities and community work. Teach relational hygiene. This is going to be required of you again and again. I see a note here from Ridge, Galena, and
They've
I
got to leave
believe.
for
Oh,
their
okay.
case. Nope.
Okay. Teach relational hygiene. A lot of people think that, oh, now that I handled it, it's done, it's over. Chances are you're going to need to do some continued toothbrushing, hair combing, bathing, psychic hygiene, possibly for the rest of your life. And that's not a bad thing. Most of us don't mind brushing our teeth, taking a bath. So psychic hygiene can be very satisfying. All of that is needed for relational, ongoing repair, for self-regulation, communication skills. Always to reinforce their internal safety, their internal sense of autonomy, their independence from and of their partner's behavior. This is about the person. This is not about their partner. If you're doing couples work, then that's a different thing. Reevaluation is sustained, secure love. Clients by this point are looking at you going, we've worked together on and off over several years. We have a sustained, secure, loving relationship in the clinical sense. It's not about attraction. It's not about romance. It's not about limerence. There's a reduction of the mixed signals or ambivalence. There's stable emotional availability because there's safety that's been established over time. You review the relational growth, explicate it, and you evaluate new adaptive responses. And there's clear boundaries that are aligned with values and mutual fulfillment. Before we start to go into your own cases, the conceptual summary, the AIP, the Adaptive Information Processing Principle, unresolved past experiences drive maladaptive responses. Unresolved past experiences drive maladaptive, exaggerated, too much of a good thing of the defense system. You overwork it, and you bring that into the present relational cues, which are the mixed signals and triggers from old wounds. That needs to be sorted out. The EMDR uses targets through earlier attachment traumas that distort perception of the current partners. Distorts perception. Distorts perception. You need to have corrective perceptions. Hussey's framework provides external behavioral sequences for relational development. EMDR gives internal healing map. There's the difference. Hussey is about the social relational objectification. EMDR is about internal healing. Client issues are attracted to emotionally unavailable partners. That's not an uncommon issue. Attracted to emotionally unavailable partners. They're stuck in mutual but no commitment phase. They're stuck in mutual but no commitment phase. Target memories of the early inconsistent caregiving or relationships need to be done. Installing new cognitions, cognitive interweaves. I'm worthy of mutual commitment. And use of future template. I can recognize what's going on, and I can walk away from mixed signals calmly, as opposed to running away or reactively reacting to it. Okay. Questions about any of this part? It's kind of straightforward from my point of view. I'm going to give you 15 more seconds, and then I want you to take 5 minutes and find a case that is a good example of something from this list. And each person that goes through presenting their case, you and I will become a team. And then it'll become just me and one person, and then me and two people, and me and three people. In other words, you kick in on helping the person who's presenting talk about what's going on. Okay? It's a growth and development phase. All right, you've got 3 to 5 minutes. Find a case, identify it, or what phase you're wanting to represent. Talk about it from the 2 models, Hussey's model of what phase, and you already know which phase from the 8-phase process. And then what did you do? How does this model work, or how it doesn't work for you? Go. I'm clocking it.
I'm happy to share. I was working with a client earlier this week, and one of my personal clients, not at EHR. I guess I'm going to posit also a question here because it's not completely well thought out, but I'll give it my best shot. So during the desensitization phase, I noticed that this client was I could tell she was like saying, she had this sensation in her stomach of heaviness, and we stayed with that. And then she said, "Oh, it's relieved," after like 2 sets, and for two, um, twice she said, "Oh yeah, it feels so much lighter. It's amazing." But I could tell that it wasn't. She hadn't actually worked through it, and it was she moved up into her headspace and was kind of just saying that happened. And then she came back to her stomach just on her own, and she did some really good seemingly some really good processing. And at the end of the session, after we had closed everything, I pointed that out to her. I said, "Oh, I noticed that, you started coming, saying it had resolved really early, and then you came back to it, and, there was more there." And so she acknowledged that that was people pleasing behavior, and, trying to please me as the practitioner, and that she has a pattern of doing that often, and putting people on a pedestal and all that. So she verbally processed it quite well. I guess in terms of the 2 models here, there's that fear of vulnerability, perhaps. I'm trying to, I guess I'm like, and here comes in the question, is I'm not quite sure how
Sure.
that lines up with the attachment in this particular layout.
Okay, let's just analyze this for a moment. The person is telling you that they have a history of putting people on pedestals and people pleasing. And the people pleasing is really an avoidance mechanism to take the risk.
Mm.
Okay, so I'm too vulnerable. I'm not safe enough. And admiring people, putting them up on pedestals, oh, I'm doing this for them. That's way back at the very first phase, which is the person's having selective perception, and the person is really just stuck in admiration and mutual attraction
Mm-hmm.
as a pattern, which is, if you ask yourself, what's the quality of their relationships? Their relationships developmentally are very young and very early.
And
Mm-hmm.
fanciful, possibly
They're
quite
fanciful.
fanciful.
Yes,
Might be having a
exactly.
fanciful reduction from the magical effect of being with you.
Right.
Mm-hmm. Mm-hmm.
And I think that when we do desensitizing, that idea of being able to distinguish, is the person really working through it, or are they just feeling, well, what are they feeling that's making them feel better? Well, what's making them feel better is, number one, is that reducing tension. And when we have reduced tension, we have relaxedness. And that can create a sense of being elevated by comparison of being distressed. But that's a confusion that they're reading the cue of my body is calming down as, oh, in my fanciful way, this is working. Oh, thank you.
Hmm.
You see? And so you have to be able to just, you need to witness that and understand that. You can reflect it back as you did. And what you can also do is you can say, so when we talk about how was it for you, and you say, oh, I feel so much better, I feel lighter. Lighter from what? Is it a body lightness? Is it an emotional lightness? Is it a cognitive lightness? Is it a heartfelt lightness? Is it a spiritual lightness? What is this lightness? Is it a chemistry? What is it? And you can help the person to distinguish that and say, well, so as soon as you start to have this lightness, what happens to your risk taking? Are you aware that you're taking a risk, or do you feel soothed that you're no longer at risk? So you really have to work that in talking.
It's an early connection, so it's you don't want to dash the transfer,
Yeah,
but you want
yeah.
to
You
build
don't
up
want
that.
to. Yeah,
You feel good in our session today, right? But we want you to be able to do this on your own as well over time. Yeah.
yes,
Hmm.
exactly. So, and so saying to a client, especially if it's an early client in an early phase of treatment, saying to the client, this is what I noticed back there when you were doing this work. That may not be the best idea at that point, at that
Hmm.
juncture, at the end especially. But if you're when you're coming back to it and you say in the next session, oh, so how was it for you over this week? What was going on? And what happened to that lightness? Oh, well, I don't know. I'm looking forward to that again. That might be the time where then instead of just verbally explaining it to them, teaching it to them, that you actually say to them, that lightness sounds like it, and the way you describe your people pleasing, that really, I wonder what that gives you. What's good about that for you? And when you talk about it, does that have any connection to the lightness? Or how does your body feel? When you used these self-regulating scales, when you were practicing them and you were able to calm yourself down, what did you have any sense of lightness then? Oh, I did. I felt better. I did feel better. Okay, so you have to learn then that when your body relaxes, when your neuromuscular system is relaxing, you feel relief. And that's not the same thing as working through. You're getting a sense of soothing. And that's one of the things that you need is to soothe. So let's make sure that you get your resources in place. And then we go in and hold on. You can come back to those things. And we want to be able to distinguish between these two things as a goal. So you and I will become alert to that together. Is that okay? All right. And then you make that agreement. And then now you've set the stage. Then you've set the stage to be able to talk about that in a way that the client won't feel rejected.
Thank
Or
you.
that, does that make sense?
Yep. Yeah, thank you. It's helpful.
Uh-huh. Okay, very good. Next. Come on, somebody else, Case.
I can share. Hi.
Go ahead.
Yeah, I have a client who is she lives in like a rural location on a neighbor island and is dating somebody for the past year who lives on Oahu. And um, I think they're kind of hovering around like the relational stage, explicit agreement, exclusive relationship. And I haven't, I've probably been seeing her for 6 months, but we're kind of just getting ready to do EMDR now. I haven't been doing it with her,
Uh-huh.
aside from the preparation and history taking. Um, she had kind of explained in the beginning that she wanted like a combination of just a space therapy to be a space to vent and with some structure. And so I'm just kind of been going slow with introducing more
Sure. Yeah.
structure.
Oh,
Uh,
know your client,
yeah.
that's know your client. Absolutely.
She's Native Hawaiian. I wanted to mention that. So, a lot of times just talking about uh family dynamics and things like that. She works in healthcare. Um, yeah, I think the fact that they don't the she doesn't see her partner. She calls him her other half. Although the amount of time they've actually spent in person is pretty limited. They don't fly over every other weekend or something. It's been like maybe once, like a long weekend every other month or every 3 months. Um,
Are there fiscal constraints?
yes, fiscal. She works 6 days a week and has a lot of family responsibilities. Doesn't have biological kids of her own, but helped raise her nieces and nephews.
Sure.
He has a disability and is on a fixed income, um, and has, health concern. Like they've talked about him moving to where she is, but there's a lot less resources and public transit and things like that. Like he doesn't really drive.
Hmm.
Um, yeah, and so I think in partly in a good way, the distance has allowed them to kind of maintain individuation, and yeah, not kind of fall immediately into like extreme codependence or anything like that. But
Right, right.
there has kind of been like a little back and forth. Like she found out that before they had met that he was posted on this group and kind of was a like a private group of like a social media group of women kind of looking out for each other saying, oh, this guy's been creeping around the clubs or hitting on me or doing this, and nothing was ever he was never like accused of anything outright,
Uh-huh.
violent or terrible, but it kind of gave her this uneasy feeling of like, who am I with? Who are you? After this is her first, she's in her mid 30s and this is her first like relationship,
Okay.
by the way. She had lost like 150 pounds before they met.
Hmm.
So really just has gone through some big transformations.
So she's molting. She's still
Yes.
she's transforming. She's doing a lot of transformation.
Yes. Yeah,
Yeah.
absolutely. Yeah. And yeah, and I think in a lot of ways is ready to kind of feel met, but isn't on a lot of levels. So it seems like they're kind of hovering.
Well, the
Um,
hovering is an important process because the hovering is we're sorting it out. We're trying to figure it out, and and this is going to go. You can only hover for so long. The problem is that hovering for too long, people become adjusted to each other and the hovering.
mhm.
And so in a way they desensitize to the discomfort of hovering. Like hovering should be like, I want it to go in a certain direction, but it's not going in that direction. But it is going, and then we did it here, but we didn't do it there. And it's like this, it's kind of a dance, and it's like, where do we go? Where do we go? How do we work it? What's the right next move? How do we stay together? How do I still do what I want to do? They do what they want to do, that whole thing. And that's part of how it gets sorted out. But at some point, it needs to really be legitimized into we have these agreements that can include whatever it is that what it really is. It's an agreement to disclose, fully disclose. This is where disclosure is that place where transparency needs to be brought to the table and we agree on what we see together
Mhm.
like that. It's not that there is one way only. That's the one thing about these words is that exclusivity thing makes it sound like it's kind of a moral thing, and it's not that. I mean, it is a moral commitment of integrity that, I'm not going to use what you disclose to me and disrobe you in front of others and embarrass you. And you're not going to do that to me. but we have that integrity together. But what the terms are and how we do it, that's between us. It's like that. And so people can reach that point, but still not know where they stand on the commitment. If it goes on in my opinion, if it goes on much more than a year, 18 months is, I think even 2 years could, in some circumstances, especially when there's distance and there's issues that like lifestyle issues, that somebody's disabled and like that. I think somebody else is molting. They're going through a lot of transformation. I think that they're really still in the phase of mutual but no commitment. And the mutuality is strong and the mutuality is there. But maybe the commitment is too much. It expects too much during a time where one person is still changing and the other person has got a lot of responsibilities to manage their disability. So they each have real things that they need to keep primary, and they can't make that commitment of togetherness primary.
It's kind of like the hovering is the hummingbirds are not deciding on the one flower or not.
Yeah, yeah. But it is a stage, therefore, of no commitment. And so then what really needs to happen if it hovers, is you need to help them really target the idea of what is that doing to you from an EMDR point of view, trauma point of view, and from a relational point of view. And what's so good about being in this no commitment phase? And so let's talk about that, because we aren't able to commit at this time. And that doesn't mean we can't continue to be mutual.
Right.
But trying to convert the hovering as a permanent state, that's the place you don't want to get caught in.
Yeah, in some ways the long distance thing has
Yeah, exactly.
I mean it's kept them from going too deep too fast, but on another level, pretty quickly into the dating, they had to think about like, well, where's this going? And like, am I moving to Oahu? Are you moving over this other place? So yeah, it kind
Or do we live this way and this is really enough and we can commit to it this way?
yeah.
Or does living together, being more proximal with each other, is that really what the issue is? And can we make that commitment? Or is it that we can say we can even be exclusive and be monogamous,
Right.
but be at a distance because right now it's working?
But the
And
disclosure
that's where
piece you're talking about,
what's that?
the disclosures, are they deal breakers? She finds
Yes.
out he's a massive snorer. Is that a deal breaker? You don't notice
Yeah.
it online.
Right.
And somebody who has a disability, is when they show up at clubs, is that person being socially condemned without being recognized? Oh, that guy is here again. Oh, that guy, that one that looks that way, that guy that's got a twitch, that guy that's got sits in a wheelchair, that guy that watches and looks, and it's like, oh, it's really it's a social condemnation. And so, is she learning about a guy that's being socially condemned for his disability,
Right.
discriminated against essentially, and not understood? Or is in fact there's something more that needs to be brought to the table, and that needs to be flushed out. And if that's contributing to the hovering, that's not a bad thing.
Mm.
Okay, but then let's put that on the table. What do you need in order to be able to talk about this more directly?
Right.
So again, you can encourage the moving forward, but the moving forward for what things that are causing the barrier.
Yeah, and in like they share location on their phones with each other so they can like track each other. So there's kind of that level of like, hey, I've got nothing to hide, but then is that overcompensating for
Yes.
like
Is it Okay, how much do you need to know that really?
right.
Okay, now that you've done it for a while and you sort of see that they were where they said they were and you were where you said you were and all of that's oh gosh, nobody's lying here.
Yeah.
Oh gosh. And it's sort of like, okay, so that's how it is. Then how much more do we need to be worried about tracking?
Mm-hmm.
Okay.
But it's
Now, if
interesting
you're
that
wanting to,
the
what,
therapeutic focus you're going on is exploring issues of past rejection, abandonment, uncertainty, develop
yes,
clear future templates for self-trust and boundaries.
yeah, there it is.
I will add too, she just lost her father. He passed suddenly in September. So there's also this parallel like grieving process and looking
Wow.
at the attachment issues and
I don't recommend that people who are in the middle of grief that they make commitments in relationships because very often parents, I don't know, no, this is kind of a therapeutic thing, and I know that we work in death and dying and have done a lot of that kind of thing, but there is a lot of evidence that when a parent dies, and no matter what the age of the child, they are likely, especially if it's of the same gender,
Mm.
they are likely to internalize that parent.
Mm.
And so they will often they'll start to live out that parent's value stance of, oh, married life is the thing.
Right.
Oh, living together. Oh, living as a family in the same community, the same neighborhood. That's a thing. I've got to do it. And before that, they were like, not so, it wasn't such a big deal for them. Suddenly it's like, why is that coming up? I don't know why that's happening, but my dad really was like that. Oh, my dad died. Oh, yeah. And how are you still being close to your dad by taking on, internalizing
Mm.
those values, oh, I'm like dad. I still have dad with me. Well, there's a way for you and your dad to have a continued relationship in a new way, but it doesn't mean you have to let it guide your lifestyle.
Right.
That can be very important. And many people slide into that. And 20 years later, they realize, oh my God, I became my father. I became my mother.
I think in some ways the focus has returned to like her family planning for his celebration of life, kind of less like kind of obsessing and hypervigilance in the relationship.
Yeah. But so I would say I would help her to identify you are really in a hovering circumstance.
Yeah.
Look, the problem here is nothing more than and nothing less than. It's your life and it's your time of life. This is for everybody. This is for everybody. How much do you want to invest of your time and your life in a hovering relationship before you say, I don't want to hover anymore. It's good with what we've got, but it's not going to go elsewhere. And so I'm going to open myself to other people.
Mhm.
I
Okay.
just wanted to, I'm sorry, David, you were
Oh,
still.
no, please.
Oh, I just wanted to point out that those groups are usually of women that are posting on social media about other guys. It's not always accurate, but or other people. It's not always accurate, but it's oftentimes warning, and especially if there's more than one and it's conspired information over multiple people, it's a big
Yes.
warning. And then
Yes.
the thing with the location, that is very controlling behavior usually. So just wanted to throw that out there.
That's right. That's right. But control in the beginning is at a certain phase of relationship in order to say, okay, I learned what I needed to learn, and now we don't need to be so concerned about the tracking thing. But if it continues, it absolutely is a control issue that needs to be brought
Yeah,
up.
and to be clear, it's also, I mean, in other circumstances, it's the most makes the most sense for safety, of course, to share our
Yeah.
location. So that's not by
Yes.
any means the same thing, right? Okay.
Right. Exactly. But so again, I think we can see that there is a lot to sort. There's this sorting out, and when you are in that sorting out, those are signals that the level of commitment has not been able to be established enough.
Hmm.
Okay. If you apply this just to a friendship that really has gone through a level of commitment making, you're going to be in my life no matter what. And that's mutual. Then you're no longer questioning a lot of the things that need to be sorted out in the way that we're bringing it up now. And if you do, it's like, I got to ask you this question. Is this really what's going on? Or is there
Hmm.
something else? Like, are you telling me that you're bringing this up because you actually do hover a little bit too much at clubs? and that might be feeling a little creepy to people, and that's what's going on. And maybe you've not done anything untoward, but the way that you're going about it, is there something like that do you recognize that? Is that what you're trying to tell me? But you see that on a friend to friend level, that would not you would have the facility to be able to do that.
Right.
Okay. But it's because there's still an established commitment. In your therapy, I trust you enough to know that you're not going to use this against me.
Mm-hmm.
Okay. Okay, we're out of time. I hope that this brought some things more clearly to the table, and that this can be very functionally applied. But it doesn't take away the necessity to become ever more skillful, like every one of us are committed to, right? We are all committed to forever growing because we're in a field that we never really have the final answers.
Thank you, David. Really, very much for your contribution to this subject and to the peer review. And again, I know other people are making some commitments about setting up appointments. Please text me to do peer review presentations.
Great.
We've got some of the
That's
text me. We'll set up some schedules. Okay. All right. Wonderful. Everyone, and have a wonderful week. Okay.
Thank you, everybody. Good luck.
Happy Thanksgiving.
Thank you.
Thank you.
So